We are recording for note-taking purposes and to make sure that we do not miss anything today that we could create to be a FAQ or direct follow-up with any of you or as a group. Again, thanks for taking the time this morning. My name is Steve Rotman. I am the Chief Executive Officer at WISHIN. We had recently another Ask Me Anything or Ask WISHIN Anything. And that was well attended. And one of the items that came from that was providing maybe a 101 of WISHIN. So that is why we have slides up here. We are not going to present to you for this entire time that's allocated. We do want this to be an open dialogue. Please feel free to use the raise the hand feature. You can simply do that by putting your hand up and Zoom will recognize you. Or you can use the function that's in the Zoom menu tray. Also, please use the chat feature for any questions that you might have. Again, we are recording, and if that's an issue for anybody, please let us know. But again, that's for our purposes to make sure we do not miss anything today. So let's get into it. Again, this is a very quick, I'm not going to spend a whole lot of time on this. 101 of WISHIN. Who we are. We are the state designated entity for health information exchange. We've been in existence going on 14 years. We are an independent not-for-profit founded by 4 organizations: the Wisconsin Hospital Association, the Medical Society, WIO, which is an all claims payer database, and WCHQ, which is a regional quality improvement organization. Our goal is to exchange clinical information that's relevant to a patient's encounter or care management purposes, population health purposes, etc., in a patient-centric way. We have a number of products, and the way we do, the way we present clinical information primarily is through our flagship product, WISHIN Pulse. I will dive into that very briefly, and again, open to any comments or questions that you might have as I'm speaking here, or throughout the duration of this quick presentation. The users of our system are not patients. The users are ED providers, clinicians, clinic staff, pharmacies, laboratories, EMS providers, correctional, in the correctional setting where medical services are provided for health plans, payers, managed care organizations, home health agencies, public health, both municipal or county, including state public health, and many other use cases. So I did not hit them all, but the purpose of WISHIN is to ease the burden of accessing clinical information. And our unofficial goal is to remove the fax machine from healthcare. That's a lofty goal. We have over 2,200 sites of care, and what we mean by that is we don't have 2,200 customers or contracts. We have a number of customers and contracts with multiple sites across the state of Wisconsin, northern Illinois, and into the upper Michigan. We do not have an exhaustive list, but the participant list we can drop in the chat here shortly. That is accessible. This map is coming out of our website. You can zoom in and zoom out of your geographic region across the state, and it will zoom into the facilities that are participating in the network. So hospitals, clinics, again, we have many, not all, of the hospitals and clinics across the state of Wisconsin. We also have independent clinics, safety net clinics, federally qualified health centers, behavioral health, mental health facilities, as I mentioned previously, correctional facilities. Um, Also, recently, within the past 12 to 18 months, ADRCs, which are adult disability resource centers, and those type of agencies in and outside of county government are now using for benefit determination. We do have all of the managed care organizations and many of the uh, private, we'll call it health plans across the state of Wisconsin. Here is the list of those health plans. And Lisa, if there are questions, you can interrupt me, especially if it's related to any slides, I can go back. Another outcome of the previous Ask WISHIN Anything were many questions related to who's in the network and maybe more so what data points are coming into the network. So we've categorized these into 3 different segments. On the left here, we have new hospitals and health systems that have come into the network in 24. I'm not going to go through these all. You all can read if there's any questions. I can address those, but I do want to call out UW Health. UW Health was a participant for a number of years to send admit discharge transfer data only. That has now expanded to all interface types that we can accept. So that includes, again, admit discharge transfer, ADT, laboratory, pathology, radiology, clinical care documents. These will all be coming in from UW Health, in addition to Unity Point Meritor. So in the Dane County area, we're going to be closing the gap in the network very soon. And then in red, there is a very large system in northern Wisconsin that will likely come into the network. We're just not at liberty to say who that is right now. Recently sending or will be very soon sending data. I will list these off as I believe it's important. Beloit, Cumberland, Amplify, which is Gunderson and all the affiliate hospitals, including Bellin. That EHR is not merged together yet, but there is a plan. Ford Healthcare, Hospital Sisters Health System, HSHS, is coming in. Marshfield is alive, and Unity Point. Again, Meritor is going to be contributing, but also Grant, Memorial Hospital, Lafayette County, and Reedsburg. It's important also to make note that for the health plans on the call, this data can be used for many purposes. One of the maybe more immediate purposes is to close the chart chase process through your HEDA season. So how this data can be used as standard supplemental data, if certified by NCQA. And if there are more questions, we can dive into that. Otherwise, those data sites or data contributors that are not certified by NCQA, that data can still be used as non-standard supplemental data, which would require primary source verification, which is something that WISHIN can offer support in achieving with your HEDIS auditor. As these data points, these new data points come in, they will not be in the category of certified data under the data aggregator validation program, but again, can be used as non-certified, non-standard supplemental data. And then to close out this slide, there are a number of non provider type organizations that are using, including ADRC, as I mentioned previously, and public health. We have partnered with WAFC. WAFC is the Wisconsin Association of Free and Charitable Clinics. We've partnered with them to bring in some of their members at a member benefit, and also through the Wisconsin Personal Care Association. There's a partnership we have with them to bring in those organizations. Again, if I'm missing questions on my team, please stop me. I'm not.
Steve, I'm gonna stop you there. We have a couple questions in. First, I want to ask if these slides are
Yeah.
going to be available afterward.
Sure, we can certainly do that.
Okay, and then two data sharing questions. One is, does UW health data include prescription information?
No, it does not include prescription information, but this is where I'm going to lean on Laura, where medication history would be available within the continuity of care document, or the CCDA. And Laura, if you have any added color commentary.
It's the reconciled med list that's in this, that will be in the CCDA. So it's not necessarily prescription fill data, but it is the reconciled med list. And then the other question that came in here that I can answer, what does WISHIN have Bellin data at this time or not? We have Bellin CCDAs, or continuity of care documents, are live right now. They started going live earlier this summer. And we also have their ADTs live very soon, hopefully within this next week or two. We will also have their lab radiology and clinical notes live as well. We're getting ready to do their load of data for that.
Thanks, Laura. Any other questions before I close out this slide deck?
There's a question here from
Okay.
Lori that says, Inclusa has very limited information access. Is there a way to expand this? Currently using it only for immunizations.
Yeah, absolutely. Inclusa is a contracted managed care organization. And if there might be limitations on the data you're seeing, we'll have that as a takeaway to schedule a call with Laura. She is the subject matter expert on making sure that you have access to the data you need. And if there are limitations, let's clear the hurdles there. Laura, anything to add based on what you know about Inclusa?
Inclusive, we do limit the data that you'll have access to based upon what's in your organization's member files. So we may want to look at what we're getting in your member files and make sure that it is including your entire patient population.
That's a great call, Laura. Thank you. Okay.
We do have a couple more questions before you move
Yeah.
on, Steve. I know it's going to
Yeah,
get
let's do
cluttered here
that.
probably quick, but one
ma'am.
is asking if Essentia Health has plans to join.
Essentia Health, some of the affiliate hospitals are participating. I can't speak to who are Essentia proper hospitals at this time, or who is using Community Connect, like Hayward. Laura, I need some help here. Who's the other one? Spooner.
Spooner is live with their data. We're hoping, but we haven't gotten a solid commitment from Ashland and Hayward yet.
Thank you. So we continue to work with these organizations and outreach. If Ascension data, or for the purpose of anybody's needs to access information, There's again motivation to go to these organizations collectively. We are more than happy to do some joint outreach to the organizations and orient them to the services we provide. Also, it's good to point out that while 2024 is the last year of the pay for performance incentive dollars available to hospitals, next year there will be a withhold, and the way to claw back the withhold is to participate in the network. And this is policy that Medicaid has developed. So we are helping hospitals achieve the greatest incentive today for the 24 measure year. Again, in 25, we can help these organizations claw back what would be withheld for their fee-for-service inpatient, outpatient claims. And through WISHIN is the only way they can do that. So whoever asked that question, if you're interested, please share with us. You can do it privately or through the chat. Another way, share with us your contact information and we can have a follow-up with you.
It sounds like there's also some interest on the western side of the state regarding Mayo Clinic, and different organizations sharing there. Caroline was saying. Here, there's another one here.
Can I, real quick,
Yep.
Lisa, I will say that we too are interested in Mayo Clinic coming in. Mayo has recently informed us that they will not be participating, as their preferred mechanism to exchange is through Care Everywhere, Care Quality. We understand that those other exchange mechanisms exist. We're not here to compete with those directly, even though indirectly, I mean, that's evidence that we do. We want to support any EHR embedded or extended exchange methodologies that organizations are using. And this just highlights that WISHIN serves all, from the largest health system down to the smallest home health agency. That is our role. So we exchange data much differently than the exchange that happens on those other platforms. That's why we're unique. That's why we are in our bias, we're indispensable, because we do things that the other exchanges cannot, especially locally. So again, if there is any motivation to jointly go out to Mayo for your organization, I forgot who, Caroline maybe was that, we are happy to do that.
That's great. Next question here is from Aaron. The question is, are limitations in the information available due to what individual healthcare organizations allow to be made available?
I would say the limitations do exist based on what organizations send to us. So to be clear, we WISHIN, the network does not go out to an EHR and pull information out. We set up the infrastructure to receive data that's pushed to us. So Laura and her team build an infrastructure where data can seamlessly move to us without an individual at the clinic or a provider having to click a button to move data to us. It happens automatically. It happens in real time, and that real time might be delayed by a number of minutes, or in some cases, if there's coding or something going on, a couple hours, but we will have that information. It is limited to what organizations do send to us. We cannot obviously share information that we don't have in the network. So we are always looking to close out those gaps that exist at an organization or in a region so that there's no blind spots.
Thanks, Steve. We're all caught up with questions right now. Matt from the WISHIN team has added a resource to the chat about it's the WISHIN participation map. So you can click on that and see which sites are participating and what type of data feeds are currently available through WISHIN. I think we're caught up, so you can go on, Steve.
Thanks. Okay, so this is a high-level dashboard. We will not spend a whole lot of time here. This dashboard is updated monthly. It's also found on our website. And I would put a plug in here that whoever is not subscribed to receiving our newsletter, you can subscribe to that through our website on the top right, I believe it is now, where you can click on the link, put in your information, and then monthly, the newsletter that Tom Roll, I'm not sure if Tom is on this call, he puts together and distributes. And through that is updated information. He puts together some new collateral, and we'll call it like a running blog that is on our resource page. Again, this dashboard is updated. Any new customers or any new contributions that organizations are sending, events that we are holding or participating in, and anything in between, so that that's a resource to you all. But with this, it's evident. I would highlight ADT transactions and the growing CCDAs. Everything else is, I mean, growing by leaps and bounds. But what we are managing every day and distributing is in the category of big data. We are moving, I would say, millions of transactions a month. And as I'll hand off to Laura, she has some really exciting news related to use. This past month, we've exceeded 500,000 record views. So Laura, anything else to add to that? Putting me on a spot here.
No, just that the use is dramatically increasing, and of course that's going to continue as we get more data in. I think, we've added recent data that was added. Steve, did you already show that slide? You did.
Yeah, the previous slide. I can go back up to it for context.
I know one of the biggest requests was to get Marshfield live, and that happened, and I think people are able to see that data. Gunderson and its affiliates is coming very soon, so that will also fill a big gap. So we're getting ready to load their backload their data as well. But I think those, were two really large requests that had been coming into WISHIN for a long time, Marshfield and Gunderson, and that will be coming very soon.
Thanks, Laura. As I mentioned previously, our flagship product is WISHIN Pulse. This is where we aggregate clinical information in a patient-centric way and provide a longitudinal record that is accessible through our secure web portal. So that was maybe some word salad here. That really means if Steve Rotman appears at your home health agency, or you're doing outreach as a public health agency, or in an ED environment, I come in and you know nothing about me. What we do is aggregate all the information from the sites of care that are sending us data to present previous admissions or encounters. A very intuitive way to find medications that are sent to us from Medicaid Medicaid sends us data twice a day. Any previous labs, if maybe I'm a diabetic and I'm having an episode, there's information about who's on my care team, and what is the medications by way of the CCDAs that I'm prescribed to. Also, we have the CCDAs again that are really a collective summary of visits or patient history. Um, in addition to that, we have single sign-ons into the Wisconsin immunization registry to look at scheduled and history of immunizations. That is essentially a couple clicks away, and you have access to that rather than going out and logging into that system separately. And also the controlled substance database, the EPDMP, that is a view of that report is integrated within our system. So again, taking all this information and presenting it in a longitudinal way. It is not click here for Pro Health, click here for UW Health. While we do have those organization specific data points that you can drill into, it is a clear and concise summary of a patient's history that we have.
Steve,
Oh, yes,
while
ma'am.
while we're talking data, we have a question here that says, could you review again how to access the VA information? And then before you get into that, I just want to let Melissa know that we will get to your question just in a moment. So we'll come back to you, Melissa. But if you could just talk, Steve, on how to access the VA information.
Sure. I will share first that we are working through an issue right now related to accessing VA data. It's by way of what we call query and retrieve through the eHealth Exchange. The eHealth Exchange is a national network that connects organizations. But Laura, can you walk us through how to access VA data and what is available?
Uh, yes. Actually, to access VA data in our system, it's a pretty simple process. I know, Steve, you've got your slideshow up. Where you, if you're in the Wish and Pulse system, when you're looking at a patient, you go to the Documents tab, and then from the Documents tab, there's a button near the top right that says Find External Documents. That Find External Documents goes out to a couple of eHealth Exchange connections that we have enabled. One is the VA, the other is DaVita. And because the VA isn't actively sending us data, we have to go and ask for it. So we ask for it. We ask if that patient is in their system. And then it takes a little bit, but it'll respond saying the patient exists or the patient doesn't exist. If the patient exists, then we press a button asking for documents, and then documents will come back to us, and you load them in Wish and Pulse and are able to view them. That view is only temporary, though. Once you log out, that view goes away. So you have to ask a second time. If you
And
stop.
I would,
Recording.
sorry, Laura, go ahead.
No, I guess I'm done.
I would, at the end of this, I think it might be the next slide. Yes, it's the next slide. Never mind the blurry image. This link, if somebody could take this link and drop it in the chat, that would be great. This will send you to WISHIN's YouTube channel, and that is about an 8-minute tutorial about how to use WISHIN and what information is available in WISHIN. So with that, I will stop sharing, and we can use the rest of the time to address any further questions that the the audience might have.
Yeah, Steve, we'll go back to Melissa's question. The question is, what is the future for WISHIN if it is not a QHIN, and how will WISHIN meet the TEFCA standards?
Yeah, that's a really good question, and we are working um, on a TEFCA position letter to send to our participants. So we are today, I would say we are positioned no different than any other QHIN or QHIN participant to exchange data. We're participating by way of the eHealth Exchange. The eHealth Exchange is a QHIN. Either you use the eHealth Exchange in we'll say the current state that exists, or you can use them through the TEFCA security protocols and under the Common Agreement version 2.0. The reason that we have not gone ahead and participated or contracted with a QHIN is one, the exchange mechanisms that we share today and offer are substantially similar to what exists in the QHIN without the QHIN flow down provisions that our current governance model and data participation agreement um, cannot accommodate right now. One is individual access. We don't have a way to validate a person's existence, as we as an HIE don't have personal relationships with individual patients. Two are the proposed exchange purposes that are downstream. Again, our governance model cannot accommodate research that is on the table as it relates to payer access or payer provider exchange. We are already accommodating that through the data sharing participation agreement that exists. As I shared previously, we have a number of health plans, all of the managed care organizations, to offer access to member data, as Laura mentioned previously, and it's a great point that we control access to payers, offering that provider safeguard that we are only exchanging data to individuals. I'm sorry, to health plans based on membership rosters, and therefore for permitted purposes: prior authorization, claims adjudication, collection of quality data, and care management. So within those 4 lanes, we are already providing value both to the providers, reducing the number of calls and queries for information, and to payers that they have immediate access as it relates to the coordination and transition to care management, prior authorization, and through the data aggregator validation program, we are offering a unique and highly valuable service to hand off essentially white glove certified supplemental data. Now, I'll say it's not perfect. There are quality and completeness that we are continuing to work on. Those that are on the call or not on the call that can attest that are DAV participants. We continue to work through what that process looks like, but the future is bright for how we can provide validated data to our payer participants on a monthly basis. And there's costs, there's significant costs associated to joining a QHIN that would have to be flowed down to our participants. So while we're independent, not-for-profit, we can control the costs, but as QHINs decide to charge for these services, that would have to come through and flow down to our participants. And we just, now is not the right time for that. And I would encourage anybody from my staff, if there's anything to add to that, But again, we are working to summarize that position in a letter to our participants regarding our position. And really, it's we are not taking this decision lightly. We are conferring with our HIE partners across the nation and their same position. And then one other question regarding the future of WISHIN. WISHIN has, for those keeping track, has been working on a technical infrastructure upgrade, which offers an enhanced community health record. And we have called that WISHIN 2.0. Again, those keeping track, we've been calling it WISHIN 2.0 since March of 21. It is not here yet. But as announced during the September 5th HIE Summit, and another shameless plug here, the newsletter will announce our next HIE Summit. That's not announced yet, but that's another opportunity to come together and ask these questions and learn from us. As announced at the WISHIN Summit, 2.0 is on track to be available August of 25. And some folks might say, well, why again so long? We had to pivot earlier this year. And as a consequence, all the effort that we put into WISHIN 2.0 for 2.5, 3 years had to stop. And then we had to, in other words, do a forklift upgrade, take all of that infrastructure, all of that data, and move it elsewhere. So it was a huge disruption to all the work that Laura and her team has done. And we are now back on track. And that is the best date I can offer today related to the future of WISHIN and 2.0. But also with the future, we are looking at enhanced use cases. We already showed the enhanced data. The network is not idle. It is not stalling. It continues to grow.
Steve, we have another question here from Shelley. Can you speak more to what WISHIN is doing to work with the submitting providers to address data quality and data integrity issues with the DAV data?
Sure. I can at a very high level, and then I will hand it off to Matt, who just came off. Yeah, Matt and Laura to talk through. There is a work group. They meet on a, I'll say they meet often. And we, again, through our partnerships with other HIEs across the nation, going through this learning opportunity, how are other folks attacking quality and completeness? And then applying those lessons learned to our processes. I'll say for the past 10 years or so, we have been satisfied with getting any volume of data in any way, shape, or form and being satisfied with that. That is how we started growing the network. And we have recognized for some time and working on how we can improve the quality by offering a better product to our participants. So Matt, Laura, anything to add there, please?
Yeah, sure, Steve. So let me expand on a couple of things you just said. The first is, so what Steve was alluding to is we have a data governance committee. It's made up of WISHIN participating organizations. So both hospital and health system representatives, as well as payer representatives, including a DAV user. And what that committee has been really focused on is identifying areas that data quality can be enhanced. And in fact, at a meeting a little over a month ago, the committee identified lab information as an area that needs some work in terms of data standardization. And the other area is information coming in around race, ethnicity, and language. So what that committee is working on is developing strategies to work with the health system and provider organizations who are submitting data to improve standardization and data quality in those two specific areas. So that's one approach, is to use our data governance committee and really, again, identify strategies and work with participants to improve information. The other thing I would say that we're working on is we are currently working with Health Catalyst to develop, our vendor, to develop some ways to really track data quality and standardization in real time in ways that we probably weren't able to, or have not been able to in the past. As Steve referenced, what we've really been focused on in terms of data quality is ensuring that the information we're getting matches the source record, and not necessarily whether organizations are using standardized codes and things like that. So we know this is an area for improvement and an area that can enhance the value that's flowing through the network. And so in addition to working directly with participants to develop strategies, we're also trying to develop tools internally that allow us to anticipate where there may be issues and work directly with customers to improve that data.
Thanks, Matt. Laura, anything to add? And I would just say Laura and her team do a fantastic job with onboarding these organizations with the specifications that we have, and that is the basis for data contribution, is the standard specifications we have to get data in. But I don't see Laura coming off mute, so maybe she has nothing more to. Oh, there she is.
Well, I guess just to add on to that, as we start getting in data in more formats, that will fill in some of the gaps, because I hesitate to say like integrity issues, because we've done a lot of validation to ensure that the data that we're receiving is doesn't have any integrity issues. There may be gaps because we don't get vitals in certain types of interfaces, but we do get vitals in care summary documents. So as we have more data completeness, I would really want to say that that's probably some of the issues that you might be seeing, is that you're not getting, quote, complete, unquote, data yet. Because if they're not sending care summary documents, you're not getting some of the vitals. And then also when we talk about integrity, we are still validating. If the customer cannot send us standardized codes, we're still validating that the codes they're sending us are accurate. It's just that it's accurate to their coding system. So we would love to get everybody on standardized LOINC codes and SNOMED codes and all of that, and we will work towards that. So I guess that's really what I would like to say, is that you will start seeing more complete data, and as we move into new cohorts, our next round of DAV validation, we will be validating all of our new interfaces. So that'll be data like Marshfields and Gundersons and the rest of Bellin, the rest of ThedaCare, UW, all of their CCDAs and everything. We'll be validating all of that in our next round of DAV certification.
Thanks, Laura. Any other questions, Lisa? Have we addressed all the questions available?
Everything in the chat has been addressed. If there's any more questions, feel free to send them through the chat now.
And I believe Tom has some questions. There's Mr. Roll. Tom has a voice for radio.
Yeah, face
there he
for
is.
the face for radio. Yes. Well, you've talked about 2.0, you've talked about TEFCA, you've talked about what WISHIN does, you've talked about the new organizations that have signed on. And there was just some discussion about DAV and the integrity of the information. So I was looking at what steps does WISHIN take to keep records secure, not just in the DAV process, but in all processes.
Yeah, that is a good question. So, security is paramount, and that security includes the receipt or transit of data, the data as it exists within our network, and then security position on how we send the data back, either through the portal or through Amazon Web Services or secure exchange protocols. Again, without security, there is no health information exchange. We go through an exhaustive and extensive security risk assessment every year. And in addition to that, many of our participants require that WISHIN go through an exercise at least twice a year, looking at our policies, our procedures, our technical controls, the controls that exist on our workforce, workstations, and such. Also, we require of all of our infrastructure, either that we manage or that is managed and hosted by our technical vendors, to be high trust CSF certified. So honestly, I cannot remember what CSF stands for, but it is one of the highest marks of security certification and validation that an organization can go through. Again, our primary technical vendor has gone through that. We have an AWS infrastructure that is protected through another third-party vendor that manages all of those controls. WISHIN also has its own set of security policies and procedures, and we conduct annual training. There's remedial training that happens throughout the year. We have, for the first time, hired on a dedicated security, I'm sorry, a HIPAA security officer who's also our IT director, Brian Meyer. I'm not sure if Brian is on the call. I mean, only if he has something to add. I won't put him on the spot, but we are doing anything and everything within the organization and through our partnerships to be vigilant. Again, keeping security at the forefront, and just recognizing that the risks are real. We have had some recent incidents within the state. There have been national and global ransomware attacks. With that, we're here to help and support those organizations to the extent that we can. And how we can do that is offering business continuity solutions where an organization might be without an EHR. If that organization has been sending us data, we can be a historical marker for those organizations. Thanks, Tom, I saw something drop in there. We recently presented at the September 5th summit all of the risks that we're aware of and we're hit over the head with every day, all day, and the protections, and going back to the business continuity, what we can do to help. Think also not only as a historical look back for an organization's own records within WISHIN, but access that would not otherwise be available in the event of a security incident, access to others. clinical information. Again, this is why we exist, not solely for business continuity, but to support the clinical operations of our participating organizations. Any other questions, Lisa? Or again, you can use the raise a hand feature if you have something to share or add, or have an open discussion verbally. We can do that.
Well, Steve, I was thinking, this is Tom
sir.
again. Probably most of the people on this call are WISHIN participants, but maybe not everyone. And so what about a quick rundown of the process? If I wanted to join WISHIN, what's the process involved? How long does it take?
Sure. This is where I'm going to lean on a few team members, Greg, Laura. So there's a pre-sales, there's a sales process, there's a post-sales, and there's an implementation. And well, as we've grown, that process has evolved and changed, and now there's new individuals managing that process. Carol is doing a fantastic job outreaching to customers, getting the attention of those that may not have been atypical WISHIN users and really opening that market. One is like pharmacies. So what we do is have the discussion, and really we say it's a pre-sales sales process, but we are not sales people. We just happen to have to wear that hat when necessary. We're here to educate the entire health community on the value of health information exchange and the benefits that it can provide to an organization and to a patient. So there's that dialogue. We present at some conferences. We do exhibiting at conferences. We attend our own conferences to learn and then bring that back to the organization. And again, Carol is primarily managing the outreach and communication. And Greg, I might hand it off to you to then hand it off to Laura about the contracting process.
Yeah, thanks, Steve. And so after we have some pre-sales calls to just understand your organization, number of participants, your kind of patient panel, et cetera, we move forward with the participation agreement, which is substantially similar for all participants that are part of the WISHIN platform. And that includes those approved use cases that Steve talked about earlier, as well as pricing information. And so then we'd help you move that through to get that executed. Once that actual participation agreement is in place, we can pass it off to Laura's team on the implementation side to, number one, get you oriented and set up with access to WISHIN Pulse and some of our other features, as well as start working on those interfaces. Laura, I really glossed over your part, which is maybe the hardest, so I'll pass it to you.
No, once we get the primary contact, we'll have a kickoff meeting and we'll talk through the scope of the project and what the implementation process looks like. We also do implementing interfaces kind of separate from actually having users access our system directly, because we can do those on two separate work streams so that organizations that join WISHIN can start getting benefit right away, as opposed to having to wait till all their data is live. And then I usually do initial kickoffs and assign it over to one of our my team members to work on the implementation piece. And depending upon the interfaces and depending upon what kind of EHR system you have and readiness, we'll work out some target timelines for going live with your data, and also work out target timelines for going live with your users.
Thank you both. Any other questions?
Yeah, Steve, we have one more question. Maybe we'll wrap it up with this one. Shelley's asking if we've given any more thought to forming a WISHIN DAV user group.
And the right person has unmuted and is now visible.
Hey, Shelley, and everyone else. Yes, It's my and our intention to start a DAV user group. As you know, we have recently restarted delivering DAV data to some of our DAV customers after a little bit of a delay. So we've been waiting to get through that restart and sort of work through any potential issues that cropped up. But our intention is to, within the next few months, start a DAV user group and really create a forum for a growing number of DAV users to discuss how they're using the data and help WISHIN think about how we can really enhance that product line. The other thing I'd add, also as a shameless plug, that hasn't been mentioned on this call is there's been a lot of interest recently about the exchange of social determinants of health data. And we sent out a survey to our participants about a month and a half ago, asking about their interest in joining a work group that would focus on the exchange of the social determinants of health information. We got a really robust response to our survey, and Greg and I are going to be kicking off and leading a work group, hopefully in December, that is early December, that is focused on that topic. So if you responded to that survey, you will see a message from Greg and or I in the coming week, in the next week, on that meeting and that topic.
All right, thanks for that. And as Lisa mentioned, with 3 minutes to go before we lean into anybody's 10 o'clock, we'll wrap here. We really appreciate everybody taking the time to join. What a surprising number of participants. Again, this is showing the value of this format or forum to have a dialogue with you all. We stand ready to support. If there are any questions that you'd like answered that we didn't address here, please reach out to us. You can do that via email or phone. wishin@wishin.org is the best and easiest way to connect with us, and we'll distribute that communication and connect with you at your leisure. Thanks again. I hope you all have a great rest of the day. Go vote, and good luck to those politicians seeking a thankless job. Have a good rest of the week, folks. Take care.